Good evening, everyone, and welcome to our February trauma webinar. I'm very excited to introduce our presenter tonight, Dr. Jill Coolen. Dr. Coolen completed her Bachelor of Science and Doctor of Medicine at Dalhousie University. Her specialty training in obstetrics and gynecology was completed at the University of Alberta before returning to Dalhousie for subspecialty training in maternal fetal medicine. She has since been practicing as a MFM specialist at IWK Health with clinical expertise in diabetes in pregnancy and fetal ultrasound. She lives just outside Halifax with her husband and two of her three kids. One has left the nest. And when not at the IWK, she can be found sailing and kayaking around the 100 wild islands, hiking in the Purcell's Cove backlands with her Ridgeback Penny, or on the basketball court or her yoga mat. Thank you so much for being with us tonight, Dr. Coolen. If anyone has any questions throughout the presentation, please just write them in the chat box and I'll read them out kind of at the end of the presentation, just in order to not interrupt the flow of this evening's presentation. Over to you, Jill.
All right, thank you, Jenna, and thanks for the invitation to present Trauma Rounds. It probably comes as no surprise, given my specialty training as a maternal fetal medicine specialist, that the topic is trauma in pregnancy. I would like to begin by acknowledging that Dalhousie University is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq. We are all treaty people reflects the peace and friendship treaties that apply to all parties involved, Indigenous and settlers alike, and that all of us have rights and responsibilities under these treaties. I would like to disclose that I'm involved in a few studies evaluating diabetes in pregnancy. In addition, I'm a board member for the Canadian Obstetrics and Gynecology Review Program that prepares PGY5 residents for the OBGYN Royal College exam, neither of which I think is a conflict of interest for today's presentation. What may come in helpful during the presentation is that I am one of the obstetrics medical oversight physicians for the critical care transport team. That gives me some understanding about regional processes. But I will disclose that my primary frame of reference is through my practice as an MFM specialist at the IWK in Central Zone. I would also like to acknowledge the pervasive presence of language that reinforces the gender binary within reproductive health. I will try to use gender non-binary language where possible, but the term maternal remains in widespread use to describe the anatomy and physiology of the pregnant person as distinct from the fetus. And I will retain this language at times to align with descriptions encountered in research, textbooks, and professional communication in obstetrics. My objectives are that by the end of this presentation, participants should be able to outline the complex management challenges that trauma in pregnancy presents, reflect on the importance of interprofessional and interdisciplinary trauma care for pregnant patients, and describe local and regional processes to optimize care for pregnant patients that have undergone trauma. Throughout the presentation, I want you to keep three cases in mind, which we will go back to at the end of the presentation. The first case is a 37-year-old Gravida 1 Para 0 at 34 weeks gestation that falls on the ice while walking to her car after work. The second case is a 31-year-old Gravida 3 Para 2 at 24 weeks gestation that is brought into the emergency department with a stab wound to her abdomen. And the third case, a 19-year-old Gravida 1 Para 0 with a gravid abdomen that is in a high-speed motor vehicle collision. So keep them in mind, and we'll start with some background. Trauma affects 6 to 8% of pregnancies and is the leading cause of non-obstetric maternal mortality. Pregnancy is an independent predictor of mortality after trauma. Pregnant individuals are up to 2 times more likely to die after trauma than their non-pregnant counterparts with traumatic injuries of comparable severity. With major trauma comes an increased risk of fetal mortality, up to 40 to 50%, from direct fetal injury, placental abruption, or maternal shock. The 3 most common etiologies of trauma in pregnancy are domestic or intermittent partner violence, motor vehicle collisions, and falls. Much less common are homicide, penetrating trauma, suicide, toxic exposure, and burns. The maternal physiologic adaptation to pregnancy is profound and vital to successful fetal growth and development. It's mediated by placental hormones and the mechanical effect of the gravid uterus, and no organ system is spared. With respect to the cardiovascular system, cardiac output increases progressively from 20% at 8 weeks gestation to 50% at 30 weeks gestation. And this is due to the increase in maternal blood volume, a decrease in vascular resistance, and an increase in the maternal heart rate. So you can see here in these figures that maternal heartbeat goes up about 15%. So that's about 10 to 15 beats over their baseline non-pregnant state. Cardiac output, as I mentioned, goes up to about 50% at 32 weeks gestation. And I'd like to highlight that you can see the difference between cardiac output in a supine position in red, and when the patient's in left lateral decubitus position, the blue hatch line. And this will come in a little bit later, and how a way to improve cardiac output in a maternal resuscitation. I don't do a lot of ECGs myself, but it's important to be aware of the changes that are common to see in pregnancy. There's about a 15 to 20% left axis deviation in pregnancy. It's common to see mild ST changes in the inferior leads, and pregnant women commonly have premature atrial and ventricular contractions. With respect to the respiratory system, because of the gravid uterus, the diaphragm is elevated about 2 to 4 centimeters at term. This leads to changes in the pulmonary volumes. The pulmonary volumes that are increased in pregnancy include tidal volume, oxygen carrying capacity, and the inspiratory capacity. What goes down are the residual volume, the expiratory reserve volume, and the functional residual capacity. There is no change with vital capacity, respiratory rate, or FEV1 in pregnancy. We often say that pregnant women are breathing deeper, not faster in pregnancy. This leads to a compensatory respiratory alkalosis, and what you would see on your ABG is a decrease in PCO2, an increase in PO2, and an increase in renal bicarb excretion. There's lots of changes happening to the hematologic system as well. Plasma volume increases by about 50% by 32 weeks gestation. This is the biggest contributor to dilutional anemia, because red blood cell volume only increases by about 20 to 30%. Normal hemoglobin for a pregnant individual is about 110. The white count can be as high as 16 and be normal in pregnancy. Because of this dilution and increase in plasma volume, as well as sequestering of platelets in the placenta, it's normal to see a reduction in platelet count in pregnancy. But it should always, if it's gestational thrombocytopenia, it should always be more than 100. And pregnancy is a hypercoagulable state. There's lots of things happening for Virchow's triad. You've got increased stasis because of decreased peripheral vascular resistance. You've got, if you have a condition like preeclampsia, might have endothelial damage, and there's lots of changes in the coagulation cascade, of which one is an elevation of fibrinogen. The fibrinogen is normally more than 4 in pregnancy. With respect to the GI system, pregnant individuals are at high risk for gastric aspiration. This is due to a decrease in lower esophageal sphincter tone, as well as an increase in intra-abdominal pressure. In addition, there's peritoneal stretching, which makes the pregnant individuals, even with a traumatic hemoperitoneum, they may not exhibit rebound tenderness on exam. The renal system, we see an increase in renal blood flow and glomerular filtration rate by about 50%, which leads to a decrease in creatinine. So you have to kind of adjust your normal range. The average creatinine in pregnancy is about 44, with an upper limit around 70. Kidneys get a little bit leaky in pregnancy, so glycosuria and proteinuria is very common. So we often see up to, normal is up to 300 milligrams of proteinuria in 24 hours. And of course, there's lots of change happening in the reproductive system. Important for those looking after a pregnant trauma patient is that the gravid uterus displaces bowel cephalad and laterally. That is important when you're thinking about penetrating trauma. And there's lots of blood flow down there. So there's an increase in uterine blood flow from about 600 milliliters per minute in the non-pregnant state to about 600 milliliters per minute at term. And the pelvic vasculature is very dilated, putting it at risk with things like pelvic fractures. So those are all the maternal adaptations to keep in mind as we talk about the maternal and fetal assessment for pregnant trauma patients. One important note is it's really important to consider pregnancy and complete a pregnancy test on all female trauma patients of childbearing age. In one big review, they found that 3% of trauma patients were pregnant, of which 11% were incidental pregnancies. The assessment, stabilization, and care of the pregnant individual is of the utmost priority. It's important to keep in mind that standard severity scoring systems that are used in non-pregnant individuals are not as accurate in pregnancy, particularly in predicting some of the obstetrical complications like placental abruption and fetal demise. Even minor trauma can lead to life-threatening obstetrical complications. The parameters associated with major trauma include hematuria, suspected internal bleeding, loss of consciousness, and fractures. So when you go in to see that pregnant trauma patient, some of the important aspects of the maternal history include getting details about the mechanism of injury. In addition, it's important to take a past obstetrical history. You'd want to know, for example, if the patient has a scarred uterus, has she had a previous cesarean section? That would increase the risk of uterine rupture with major maternal trauma. In addition, you'd like to know if there were any previous obstetrical complications. I can often be heard saying, whatever happens in one pregnancy is more likely to happen in another pregnancy. So if the patient's had a previous abruption, they would be more likely to have a recurrent abruption. You also want to get information about the current pregnancy. Of utmost importance is establishing the pregnancy dating. So you'd like to know, like, her last menstrual period, has she had any ultrasound, does she know her due date, and whether or not there have been any complications thus far in the pregnancy. For example, it'd be very important to know if the pregnant trauma patient has been diagnosed with preeclampsia in the current pregnancy. Individuals with preeclampsia are intravascularly depleted and often have reduced renal function, both of which put them at increased risk for pulmonary edema with fluid resuscitation. For every pregnant trauma patient, it's important to ask about the cardinal symptoms, which there's 4, whether or not the individual is experiencing any abdominal pain or contractions, if they've experienced any leaking of fluid per vagina that would make you suspicious about rupture of the membranes, have they experienced any vaginal bleeding, and are they perceiving fetal movements? In addition, if the individual comments or had any witnessed seizures, that might help you to know whether or not there's been any head trauma. But of course, any seizures in pregnancies, you should think about eclampsia, particularly if the individual's had any elevated blood pressure or proteinuria in the pregnancy. In one of the reviews I read in preparing for this presentation, I saw this really helpful mnemonic about all the important aspects of the maternal history. And very cleverly, the mnemonic is called CODE. C stands for complications of the current pregnancy. O, the obstetrical history. D, the pregnancy dating. And E, the event details, including the cardinal symptoms that I just reviewed. The goal with the maternal physical examination is to identify any maternal and fetal injuries. Thus, it's important to expose and examine all body parts, taking particular care in examining the abdomen. You're looking for distension that might highlight or a suspected intra-abdominal hemorrhage or viscous perforation. You want to look for any bruising of the abdomen, and if there's been penetrating trauma, any entrance or exit wounds. As part of that abdominal exam, it's important to do a careful examination of the uterus. Fundal height will help establish pregnancy dating. Assessing uterine tone might highlight an increased risk of abruption, and palpation of any fetal parts might highlight the possibility of a uterine rupture. If the patient is describing any uterine activity or contractions, a vaginal examination to assess cervical dilatation, effacement, and station may be part of the physical examination, but this should be deferred until placenta previa has been ruled out, either by looking up the patient's anatomy scan through their medical records, or doing a point of care ultrasound to localize the placenta. When evaluating a stable patient who might be at risk for preterm labor, fetal fibronectin testing can be considered. If the patient describes any leaking of fluid or bleeding per vagina, a sterile speculum examination may be indicated to assess for pooling of amniotic fluid and/or a source of vaginal bleeding. Initial management of the pregnant trauma patient is focused on maternal assessment, resuscitation, and stabilization. And there's some special considerations that I'm going to highlight in the next few slides because we have to modify contemporary trauma care principles for the pregnant individual. One of the reviews I found that was really good was by Queensland Health in Australia, and this is their primary survey for the pregnant trauma patient. A really great document if you are interested. With respect to the airway, some special considerations include consideration of early intubation. This should be considered whenever airway problems are anticipated, because pregnant individuals are at increased risk for difficult intubation. Failed intubation is actually 8 times more likely. The reason why pregnant individuals are more difficult to intubate is because of the gestational weight gain. They can have some respiratory tract mucosal edema, that decrease in their functional residual capacity that I mentioned earlier, and increased airway resistance and increased oxygen requirements. The reviews describe having the individual in a 30-degree head-up tilt if you're not worried about spinal injury, ensuring there's pre-oxygenation, cricoid pressure, and a smaller ET tube. I mentioned earlier that pregnant individuals are at higher risk for aspiration. So with respect to the airway, early placement of an NG tube is recommended if the individual is unconscious or semi-conscious. Some special considerations for breathing. Pregnant trauma patients should have continuous oxygen saturation monitoring with supplemental oxygen used to maintain the oxygen saturations greater than 95%. And that's because of the increased maternal oxygen consumption that's normal in pregnancy, as well as the sensitivity of the fetus to maternal hypoxia. If a thoracoscopy tube is indicated for the pregnant individual, it should be placed 1 or 2 intercostal spaces higher, because as I mentioned, there is elevation of the diaphragm by 2 to 4 centimeters by the gravid uterus. Some special considerations for the circulatory system include placement of 2 large bar IVs with early consideration of an arterial line with major trauma. This facilitates rapid crystalloid infusion, intravascular volume expansion, and possible blood transfusion. If a central line is required, it should be placed above the diaphragm. For example, femoral catheters should be avoided because of the uterine compression of the vena cava, reducing venous return. When giving emergency blood to a pregnant individual, it should be O negative and ideally Cal negative to avoid maternal antibody formation. I know for sure, I was able to confirm that at the IWK, all of our emergency blood is both O neg and Cal neg, but I wasn't able to confirm that for the other sites. Really important consideration with respect to blood products is maintaining fibrinogen levels greater than 2, because remember, normal is 4 in pregnancy to ensure appropriate, adequate coagulation. In pregnancy, the goal ideally is to avoid vasopressors unless there's no response to fluid administration, because vasopressors can decrease placental perfusion. Bicarbonates should be used with caution because, like I said, pregnant individuals are in a compensatory respiratory alkalosis, and rapid correction of maternal acidosis can reduce this compensatory hyperventilation. And if military anti-shock trousers are being used, the abdominal portion should not be inflated. This is contraindicated because it can reduce placental perfusion and increase cardiac workload. And probably the most commonly discussed special consideration for circulation is avoiding supine hypotension. Laying on their back, the gravid uterus will actually compress the IVC and abdominal aorta, which can decrease cardiac output by about 30%. So I've got a little picture from the Queensland guideline. You can see in the top figure, when the patient is supine, you get compression of the IVC and the aorta, but through tilting the patient left laterally using a backboard, you can alleviate that compression. So you want them up about 15 to 30 degrees. The backboard is particularly helpful if you also need to do chest compressions. If you don't have a backboard, you can also do this manually by having an individual pull the gravid uterus to the left, or from the other side, pushing the gravid uterus to the left. It's important to know the vital sign changes that we see in pregnancy. So I already mentioned that heart rate goes up about 15%, which is about 10 to 15 beats per minute. During the 3rd trimester, a pregnant individual will often lose 1.5 liters of blood before there's any clinical signs of hypovolemia like tachycardia or hypotension because of the increased blood volume. And actually, the first sign that there may be a hypovolemic shock might not be maternal vital signs, but the fetal vital signs, because the fetus, there will actually be a decrease in uterine perfusion first, and you might see an atypical or abnormal fetal heart rate tracing. So I've also included the secondary survey from the Queensland Health Trauma in Pregnancy Guidelines. And I'm going to highlight some special consideration for the secondary survey, starting with imaging. So there's often a reluctancy to order imaging studies for pregnant individuals out of concern about the risk of fetal exposure to ionizing radiation. But these anxieties that are both by clinicians and by patients are often disproportionate to the actual risk. You can see here in this table that there's no single diagnostic procedure that exceeds 5 rads, which is the amount of ionizing radiation above which has been associated with fetal anomalies and pregnancy loss. So your standard trauma series CT would not exceed 5 rads and should be done if it will expedite maternal treatment and diagnosis. We do have to keep in mind that the risk is cumulative. So you want to do the test that's going to give you the answer and try to avoid repeated imaging. With doses above 5 rads at less than 5 weeks gestation, there is an increased risk of miscarriage. With more than 5 rads between 5 and 10 weeks gestation, that's the period of organogenesis, embryogenesis, there is an increased risk for structural anomalies. The CNS system continues to develop across gestation beyond the period of organogenesis, so the central nervous system remains at increased risk with cumulative doses above 5 rads after 10 weeks gestation. And there can also be adverse effects on fetal growth above 10 weeks gestation. But the bottom line is that maternal radiographic studies should not be delayed or deferred. With respect to gadolinium-based contrast agents, toxicity has been shown in animal studies. So at one time we said absolutely not, contraindicated in pregnancy, but there have been no adverse effects reported in humans. So now guidelines say that they can be used if the maternal benefit outweighs the potential fetal risk. When appropriate, if you're can avoid ionizing radiation, an alternative imaging device, of course, or modality would be ultrasound. I know you got in the emergency department, focused abdominal sonography and trauma is commonly used for rapid identification of hemopneumothorax, pericardial tamponade, and fluid in Morrison's pouch or splenorenal recess. And actually, for the detection of free fluid, there's no difference in the sensitivity and specificity in pregnancy, but does become more challenging with advancing gestation because the gravid uterus can obscure some of the desired targets. Ultrasound can also be used for fetal assessment. This is what I do day in and day out. We use ultrasound to determine gestational age, to demonstrate the presence or absence of fetal cardiac activity, to localize the placenta, to assess amniotic fluid volume, to assess fetal well-being, to measure the cervical length, to detect fetal anemia, to detect fetal injury or rupture. But one really important point I wanted to make about ultrasound is that it's not sensitive in diagnosing placental abruption. Placental abruption is a clinical diagnosis. It's important to keep in mind the laboratory changes that we see in pregnancy. There's alterations in the normal ranges for, as I mentioned, white blood cell count. We see that leukocytosis in pregnancy. With hemoglobin, we have dilutional anemia with serum creatinine. Alkaline phosphatase actually goes up in pregnancy because it's produced by the placenta. D-dimer is very commonly positive in pregnancy. And as I mentioned, there's an increase in fibrinogen in pregnancy. The one thing to do for laboratory tests in the pregnant trauma patient is remember to add fibrinogen and a Kleihauer-Betke to your standard trauma panel. A fibrinogen level more than 4 is normal in pregnancy. 2 is needed for adequate coagulation. And if you see a fibrinogen less than 1, that means that this patient is in trouble. There's likely a consumptive coagulopathy. They may be in DIC, maybe they have an abruption. With respect to diagnostic peritoneal lavage, it's rarely used in pregnancy because abdominal CT has become a less invasive alternative. But if there's a concern that there is abdominal blood by CT or ultrasound, likely the recommendation is to proceed with the exploratory laparotomy with midline incision. And whether or not to do a concurrent cesarean section will depend on the fetal status, the fetal well-being, and the gestational age. So where should this maternal and fetal assessment take place? So these are the SOGC transfer guidelines. Minor trauma for pregnancies less than 23 weeks. It's appropriate to do the maternal assessment in an emergency department. Whereas with minor trauma greater than 23 weeks, the recommendation is for the patient to be seen in a labor and delivery triage. With major trauma, the recommendation from the SOGC, the Society of Obstetricians and Gynecologists of Canada, is that the patient be seen in an emergency department with a trauma unit, regardless of the gestational age. But if there's uncertain severity or an uncertain gestational age, the best place is still an emergency department. And who should be involved in the maternal assessment? Well, the optimization of outcome, particularly in severe trauma, mandates an interprofessional and interdisciplinary team involving trauma surgeons, emergency medicine physicians, nursing staff, technicians, anesthetists, obstetricians, and neonatologists. So how about those obstetricians? Well, Urgent obstetrical consultation is recommended with a viable fetus, so that's greater than or equal to 23 weeks gestation, with suspected uterine contractions, with suspected or confirmed placental abruption, or with a traumatic uterine rupture. We can play a major role in determining gestational age, optimizing uteroplacental perfusion, providing information about the risks of radiation exposure and medications, to assess fetal well-being, and deciding upon and executing an emergency or perimortem cesarean section. So what are the best ways to determine gestational age? Well, if you have a conscious patient, you may be able to ask them their last menstrual period or due date. If you have access to their medical records and they've sought prenatal care, we would normally use the first ultrasound performed after 7 weeks gestation to date the pregnancy. If the patient is unconscious or perhaps hasn't sought medical care, we would typically use fundal height, and I have a picture to show you how that works. Or you can use point of care ultrasound. An easy way to kind of get a sense of gestational age is actually to measure the femur length. So with respect to fundal height, the fundus comes out of the pelvis at about 12 to 24 weeks gestation. By 20 weeks, it should be at the level of the umbilicus. And then by term, it's up under the zippy sternum. What we do clinically at a prenatal visit is actually we take a measuring tape and we measure from the pubic symphysis up over the gravid abdomen to the top of the fundus, and the centimeters corresponds pretty close to the weeks. So like 24 centimeters would be about 24 weeks. Using point of care ultrasound, you can actually measure the femur length. So this is the fetal buttocks. This is the femur, is the bone horizontal across the screen with the knee. And you measure the diathesis, so the shaft of the bone, from end to end. And if that measurement is more than 4 centimeters, it's helpful here. If you use an obstetrical package, it will tell you exactly the gestational age for your measurement. But if you don't have that and you've just got a distance, look for 4 centimeters. If it's more than 4 centimeters, the fetus is likely more than 23 weeks, which is like what I said earlier, we consider viable. With the fetal assessment that's recommended for a pre-viable fetus, less than 23 weeks gestation, is just documenting the presence or absence of fetal cardiac activity. With a viable fetus, more fetal assessment is required. So you would want to initiate cardiotachography, which is monitoring of both contractions and the fetal heart rate, as soon as the pregnant individual has been stabilized. And you would continue that monitoring for at least 4 hours. The monitoring can be discontinued if all of the following is seen: contractions less than 1 every 10 minutes, no vaginal bleeding, no abdominal pain, a normal fetal heart rate tracing, and normal maternal vital signs. The normal fetal heart rate is between 110 and 160 beats per minute. With an abnormal fetal heart rate, which could be a fetal heart rate that's bradycardic, less than 110, or a sustained tachycardia, more than 160, this can be a sign of compromised fetal perfusion and oxygenation, so a baby that's in trouble, which may also be a sign that there's been a maternal hemodynamic compromise. Because like I said, you might see this before you see any other maternal signs of shock, like tachycardia or hypotension due to the expanded maternal blood volume. If you have both normal fetal monitoring and a normal maternal physical exam, that has a really great 100% negative predictive value that you're not going to see a major adverse fetal outcome. So now that we've gone through all the background, we're going to go back to the cases that I showed at the very beginning. So the first case was a 37-year-old gravida 1 para 0 at 34 weeks gestation that fell on the ice walking to her car after work. So this is a patient that I see very commonly this time of year. and would likely present to the IWK, early pregnancy, early labor unit, if they lived in HRM. So I get the call that this patient is in our early labor assessment unit. As I'm headed there from wherever I was in the hospital, these are the things that I'm going to be thinking about. I'm going to be thinking, has this patient sustained an injury herself? Like, did she hit her head when she fell? Did she sustain any trauma to her abdomen? That would make me more worried about something like placental abruption or fetal maternal hemorrhage. I'm definitely going to want to ask her about the cardinal symptoms. Is she having any contractions? Is she having any leaking of fluid? Is she having any vaginal bleeding? And is she feeling any fetal movement? And because she may have had trauma to her abdomen, and there can be fetal maternal hemorrhage, I'm going to want to know her blood type. I purposely made this patient 34 weeks gestation because if she's Rh negative, she would have received Winrow at 28 weeks gestation, and we're now 5 weeks later. And that's important because she would definitely need a redosing of Winrow if she's Rh negative. Up to 30% of pregnant individuals will sustain a fall in their pregnancy. Falls are much more common in the 3rd trimester because of this altered center of gravity from the gravid uterus leading to lumbar lordosis. Fortunately, less than 10% of falls in pregnancy will result in significant maternal or fetal complications, unless there is direct abdominal trauma. The worry with direct abdominal trauma is that there could be a placental abruption. The placenta has very little elasticity, and it's very vulnerable with forces of shearing at that placenta myometrial interface, leading to separation. And placental separation can lead to either overt or occult bleeding. So when I talk about occult bleeding, I'm talking about those concealed abruptions. With a significant placental abruption, there can be a consumptive coagulopathy, and the patient may develop DIC and hypofibrinogenemia, which can lead to maternal and fetal compromise. Placental abruption is the most common cause of fetal death with blunt trauma. If a placental abruption is going to happen, most of the time it will occur within 2 to 6 hours of the injury. That's why we do that monitoring for 4 hours after. Almost all placental abruptions will occur within 24 hours of the trauma. As I mentioned earlier, placental abruption is a clinical diagnosis. Ultrasound just isn't very good. Some will show up, the most significant ones will show up on an ultrasound, and some will show up on CT or MRI, but in general, it's a clinical diagnosis. The patients present with severe abdominal pain, uterine tenderness, and often contractions, which puts them at risk for premature rupture of the membranes and preterm labor and delivery. They have increased uterine tone, and the kind of the severe placental abruptions that I've seen in practice, the uterus is rock hard. Like, it's so incredibly firm. It's easy to tell the difference. Like I said, there can be overt bleeding, but there can also be occult bleeding. And because of the separation of the placenta, decreasing oxygenation of the fetus, you can see atypical or abnormal fetal heart rate tracings. And because of that possible consumptive coagulopathy, with blood work, you can see coagulation abnormalities. The management of a placental abruption will really depend on the maternal and fetal status. An immediate cesarean section would be indicated if there's deterioration in the fetal condition or if there's maternal hemodynamic instability, even if the patient is remote from term. With the placental abruption, it's important to consider administration of Rh immunoglobulin, Winrow, and if the patient's at risk of preterm birth, antenatal corticosteroids to promote fetal lung maturation. Traumatic placental injury can lead to fetal maternal hemorrhage in 10 to 30% of cases, which can have two potential sequelae. One is triggering RHL immunization. Although we focus on D, it can also lead to sensitization of other antibodies like CAL. But for Rh negative individuals that sustain trauma, they should be given Winrow, 300 micrograms if they're more than 12 weeks gestation. And they should get one dose, ideally as soon as possible, but within 72 hours. A Kleihauer-Beck key should also be measured to determine whether or not there's a need for any additional doses, because the Kleihauer-Beck key will actually let us know how much fetal blood is in the maternal circulation. The other potential sequelae of a fetal maternal hemorrhage is fetal anemia. So if there is fetal blood, and remember, a fetus has a small blood volume, so it doesn't take a lot of fetal maternal hemorrhage for a fetus to become anemic. And if a fetus becomes anemic, they can go into a congestive heart failure and fetal mortality. So if a Kleihauer-Beck key shows that there's been a significant fetal maternal hemorrhage, will actually monitor the fetus for anemia using ultrasound. And the way we do that is by measuring the peak systolic velocity by Dopplering the middle cerebral artery. And if we diagnose a significant fetal anemia, we can actually treat that with an intrauterine fetal transfusion. And of course, this is for like the stable pregnant trauma patient. Antenatal corticosteroids should be considered when there's an increased risk of preterm birth at 23 to 35 weeks gestation, little typo there. And when we give steroids, in the past, the one that's been shown to have the most benefit is betamethasone, but that's a little hard to get these days. So we have been using dexamethasone, 6 milligrams IM Q12H for 4 doses. And antenatal corticosteroids in fetuses born preterm have shown benefits in reducing respiratory distress syndrome, decreasing perinatal mortality, decreasing necrotizing enterocolitis, and decreasing intraventricular hemorrhage. So moving on to the second case, the 31-year-old Gravida 3 Para 2 at 24 weeks gestation that is brought to the emergency department with a stab wound to her abdomen. These patients are less likely to show up at the IWK and more likely to show up in one of the emergency departments. The things to consider is, where is the location of the penetrating trauma? Could there have been any maternal or fetal injury? Could this be a result of intimate partner violence? And does the patient need a tetanus shot? Fortunately, penetrating trauma in Canada is very rare. The sequelae will depend on the gestational age and the size of the uterus. With penetrating trauma in pregnancy, maternal injury is less likely because the uterus will actually protect the maternal viscera, but this puts the fetus at risk of increased risk of injury. The management of a penetrating trauma in pregnancy is, of course, stabilizing the pregnant individual and then determining next step, whether that's imaging or surgical exploration. The indications for surgical exploration are the same as in non-pregnant individuals: a positive diagnostic peritoneal lavage, free air, progressive abdominal distension, a declining hematocrit, or abdominal wall disruption. And again, whether or not to do a concurrent cesarean section will depend on the gestational age, any signs of fetal compromise, or any uterine injury. Every pregnant individual that sustains trauma should be questioned about intimate partner violence, which can escalate in pregnancy. It's reported in approximately 7% of pregnant individuals, and this is likely an underestimate. With trauma from intimate partner violence, the most commonly struck area is the abdomen, increasing the risk for abruption. So it's a major risk factor for adverse maternal and fetal outcome. Accurate documentation is important for legal purposes, and an important aspect of care for these individuals is often consulting social work. Tetanus vaccination is safe in pregnancy. In fact, it's routinely given, not for tetanus, but for pertussis. at 26 weeks gestation. So I made this patient 24 weeks to highlight that she would not have yet received her booster in the pregnancy. And the third case, a 19-year-old gravida 1 para 0 with a gravid abdomen, is in a high-speed motor vehicle collision. Things to consider for this case is, I told you she had a gravid abdomen, but we don't yet have an estimation of her gestational age. Important would be to determine the severity of her injuries, and if she has had a cardiac arrest, should we be considering a perimortem cesarean section. Motor vehicle collisions are the leading cause of maternal death, and maternal and fetal outcomes will vary depending on the mechanism of the collision, what the acceleration and deceleration velocities were, and whether or not the pregnant individual was ejected from the vehicle, and whether or not there was use of protective measures like seat belts or airbags. Deployment of airbags have been associated with adverse events such as uterine rupture, placental abruption, and fetal death, but this is likely a reflection of the severity of the trauma, not an actual causal association. Seatbelts are safe and should be worn at all times in pregnancy, with just a slight modification. The bottom belt, the lap belt, should be below the gravid uterus across the lap rather than across the uterus, and the shoulder belt should be placed between the breasts. I just wanted to highlight that pelvic fractures are of extreme concern in pregnancy. They can result in injury and laceration to the dilated pelvic vasculature or to the highly perfused uterus, or injure the fetus. And this can lead to rapid exsanguination. So pelvic binders should be applied immediately if pelvic fractures are suspected. With respect to how they affect mode of delivery, if you have a stable pelvic fracture, a vaginal birth is still possible, but if there's an unstable pelvic fracture, the recommendation is cesarean section. And a quick note on perimortem cesarean section. It's recommended in viable pregnancy, so those 23 weeks or greater, no later than 4 minutes after maternal cardiac arrest. And the rationale of doing the cesarean section is to aid with the maternal resuscitation. Evacuating the uterus will improve the efficacy of chest compressions by alleviating aortic cable compression and allowing adequate venous return. And in some cases, it's to save the baby. And that's why it needs to be done quickly, because fetal survival is only 5% after 15 minutes, and those survivors would be at very high risk for adverse neurologic sequelae. With high velocity collisions, these pregnancies are at very high risk for fetal demise, preterm labor, and abruption, and hospitalization should be considered for at least 24 hours for increased maternal and fetal surveillance, and they should have a fetal ultrasound while admitted. If everything's good and they do get home, the ultrasound should be repeated in 2 weeks' time to document normalcy after the traumatic event. And lastly, I'd like to highlight some local and regional processes. So for this, I reached out to some of the folks at EHS and LifeFlight. With minor trauma region in Nova Scotia, patients should be brought to the appropriate emergency department within their region. With one exception, in HRM, they will all go to the QE2 emergency department, bypassing Dartmouth General, Cobequid, and sometimes Hants. With major trauma, there will be, or trauma team activation, and a fetus less than 20 weeks, all of those patients will go to the QE2 emergency department. When there's a trauma with a viable fetus, that's where someone like me might get involved to help with transport decisions. But who are you going to call? So we're here to help. This is the team that I work with. We're the obstetrical medical oversight physician critical transport team, and we can be reached through the IWK switchboard or through EHS LifeFlight. If a patient is transported to one of the regional maternity hospitals highlighted in yellow, if you need an obstetrician, you would call the OB/GYN on call at that site. for a pregnant trauma patient at the QE2 emergency department, at any gestation, you can get the gynae resident on call to come to the emergency department. If the fetus is less than 20 weeks gestation, it would be the gynae staff on call. But if the fetus is greater than 20 weeks gestation, the MFM on call will come to the QE2. And for all three of these individuals, we can be reached through the IWK switchboard. What about if a fetal assessment is required in the QE2 emergency department? Well, there are ultrasounds available. One is located in the emergency department and the other in the ICU. But if we're coming over from the IWK, we can bring a Doptone, or we can bring the cardio tachography machine from the IWK. And this is for the IWK folks. It's actually located in the prenatal clinical nurse specialist office up on the 7th floor. And after hours, if Kelty's not in her office, you can have security open her office. She said that would be okay if you need to grab it and bring it over to the QE2. We do have an algorithm for unplanned births at the QE2, and it starts with the HI attending physician contacting the MFM on call to activate LifeLight. That'll bring the neonatal resuscitation team to the QE2, and we would also be responsible for notifying the anesthetist at the HI. This algorithm, I know for sure, is available on the IWK Pulse. Also in Pulse, you can find this information, which is where the emergency birth supplies are located. They can be found in 4.2 in the burn unit storage area, and it has everything you need except for the incubator, which is in the emergency 3 IMCU back hallway. Now, if the trauma patient comes to the IWK first, like they had that fall on the ice, after we've assessed the patient and determined that there's no obstetrical concerns, maybe we did that 4 hours of monitoring and they met all the criteria for monitoring to be discontinued, we might then call the QE2 and ask for the patient to be transported to the emergency department to be assessed for other injuries. Maybe they hit their head when they fell and need an assessment or a CT head, because it's more difficult for us to get adult imaging at the IWK, and there's just we don't have all the adult medical and surgical specialties that would be available at the QE2. So in summary, with sufficient knowledge of normal maternal physiology and potential pregnancy-related injury patterns, a team caring for a pregnant trauma patient is better equipped to manage them, which will reduce maternal and fetal morbidity and mortality. And it's important to remember that even minor trauma can lead to life-threatening obstetrical complications. The interprofessional and interdisciplinary team will optimize maternal and fetal outcomes. We're here to help. Urgent obstetrical consultation is recommended for pregnant individuals with a viable fetus and suspected contractions, placental abruption, and uterine rupture. We're unfamiliar with the emergency department and contemporary management of major trauma. And those of you who work in the emergency department or trauma team may be unfamiliar with aspects of emergency obstetrical care. So we all need to work together to ensure the best outcomes. And we do have local and regional processes in place to optimize their care. So thank you. I apologize, I haven't left a lot of time for questions, but I am certainly happy to take them.
Wonderful. Thank you so much, Jill. There were 2 questions throughout your presentation there. I'll just read them off to you. The first one is from Matt Mackin. Numerous discussions have arisen regarding perioperative pregnancy testing. If the patient is conscious, do you recommend asking permission prior to testing for a patient of childbearing age?
That didn't actually come up. I guess most of the reviews I read was around the patient showing up and maybe they didn't qualify whether the patient was conscious or unconscious and whether or not you were able to get consent. I don't know if it's part of the automatic trauma panel that's sent, whether beta HCG is on that. But certainly all the guidelines and reviews I read said that all pregnant trauma patients should be considered pregnant, and pregnancy tests should be done. I mean, of course, I'm in favor of always getting consent from the patient, but I guess that you'd have to, I don't know what local practice is.
Right. Okay. Perfect. And Emma Landry, she's one of the Lifelight RNs on the adult team. Pre-hospital setting, is there tolerance for permissive hypotension and trauma with pregnancy with unknown injuries? Is the MAP target still 65?
Again, I didn't come across that level of detail. That sounds like a very good question. That maybe one of the emergency doctors or trauma team adult physicians could answer. But I guess what I've highlighted is that hypotension is less common in pregnancy because of increased maternal blood volume. And if you see hypotension, that's very worrisome, that they've likely lost at least 1.5 liters. But and it's important to remember too that in minor trauma, your blood pressure does go down just normally in pregnancy because of the progesterone effect on the smooth muscle and the decreased peripheral vascular resistance. So it's not uncommon for our patients to, like healthy patients, to have low blood pressure in pregnancy.
Awesome. And Dr. Rob Green, our senior medical director, just wrote in the chat, no to permissive hypotension.
It didn't sound like a good idea, but I didn't come across it in my review. So thanks for jumping in.
Perfect. Awesome. If nobody has any more questions, and Emma says, that's great, thank you. If there's no more questions, then that's great. We're right on time. Thank you so much, Jill.
No, you're very welcome. I hope it was helpful to those in attendance.
Yeah, absolutely. Thanks, everyone. Good night.